Thank you very much for inviting me. Now, Wallace has already given some of the main conclusion from the report that I'm going to talk about. In this case, I'm representing VKM and not my institute. And also, this is not a risk-benefit report. This is actually an evaluation, so just remind ourselves on that. I just would like to give the terms of reference for our work. So, of course, what were the negative health effects of omega-3 fatty acids? Is it possible to set a tolerable upper level, intake level, UL, for the N-3 fatty acids? We also discussed a little bit about ethyl esters. I won't come into that today. And also, what are the positive health effects of the omega-3 fatty acids? And also we had some about the intake level in the Norwegian population, which I will not go into detail with. So already given by Wallace, we looked at maybe the most important, which we thought of in the beginning, was bleeding time. And as given by Wallace really thoroughly, the background for the fear of bleeding time is highly debatable. Anyways, we looked at lipid peroxidation, inflammation and modulated immune function. We had impaired lipid and glucose metabolism and gastrointestinal disturbances. So we were kind of keeping to only these. We didn't look to mother and child, infant. And then we looked at the positive outcomes, cardiovascular function, inflammation, immune function. We looked at central nervous system and mental health function, and other reported health effects that we call sum up there. So when we looked into bleeding, we actually looked at an increased bleeding time, 6.9 grams, and in coronary heart disease patients on anticoagulant medication. So actually they were, as well as also given a detail, they were on medication, but still there was no, as become evident, there's no negative health effects regarding bleeding complication in connection with EPA and DHA supplementation. So, because the medical doctors, they have to report any complications, and when we looked into that, no such complication have been reported. Lipid peroxidation, that's a big issue, but also when we look at the number of studies that have reported on lipid peroxidation, most of these did not show any increase in lipid biomarkers, but there's a challenge, and that is that we have one large study where we actually see that we have an increase in the so-called thiobarbituric acid reactive substances, TBARS, in plasma. Many of you are familiar with the TBARS, I guess. But as also been mentioned by Wallace, this in vivo lipid peroxidation and TBARS, the relationship here is quite uncertain. And also, which has been mentioned, there's no direct link on these oxidative stress biomarkers and defined as a risk markers for disease or risk factor for disease. So there's a challenge there. So we concluded that the clinical relevance of lipid peroxidation is therefore unclear. When you go to inflammation and modulated immune function, so we have looked a little bit on C-reactive protein after intake of marine omega-3 fatty acids, and up to 5 grams. We noticed that in one trial there's an increase in soluble WCAM and selectin, E-selectin, which actually denotes or indicates that you have a reaction in the endothelium, which might not be good, but again, we really don't know, as will become evident there, that this low-grade inflammation, we have a concern about it, but it's not established really the clinical relevance of this. So again, it's really hard to make any firm conclusion. When it comes to impaired lipid and glucose metabolism, this is a rather new area, I would say, that's gained a lot of attention. And we didn't actually find no effect then on glucose control from 0.8 to 4 grams per day. However, it's been mentioned that particularly in the German report, they have put much emphasis on the slightly increase in LDL cholesterol. And actually, that was in a quite low dose, down to 0.8 to 4 grams. And we actually couldn't find any dose relationship. Neither did Wallace. They couldn't see that. But this LDL cholesterol, this small rise, 1 to 3%, I would just add a personal comment which we didn't put into the report. If you imagine that you have if I take a blood sample from myself and I send it to 5 different laboratories, probably each laboratory has a certain of uncertainty on their method to analyze this, ranging from 5 to 15%. So again, this is rather quite astonishing that they put so much emphasis on this. The other thing is that, which we actually noted, and we got support from the steering committee as well, that since these patients probably have a much larger challenge with the high triglyceride level, and this comes down, despite that you have a minor increase in the LDL, so we didn't put too much emphasis on that you had this modest effect on LDL cholesterol. Perhaps where we have the most findings and reports on so-called adverse effects relates to gastrointestinal disturbances. And that includes cramps, flatulence, regurgitation, vomiting, diarrhea, and so forth. But as mentioned by Wallace, this cannot be separated or linked solely to EPA and DHA. It's rather linked to the fat. So it's the total fat intake that affects. I would say that the answer, you already know, that we couldn't actually establish a UL. We don't have enough data. And in the studies investigating ALA, we also looked a little bit on ALA. No negative health effects have been observed, so up to 8 grams. And other bodies as well have concluded there's no rationale to go for intolerable upper intake level for ALA. Then we turned a little bit into the positive health effects. We know that there's, of course, papers coming showing that it goes a little bit in both sides, but clearly, when it comes to cardiovascular functions, it's clear that we have positive effects. And primary prevention, as we see it, is it's not advice and then see what people actually. It's to give, treat or to give to rather healthy people. Has been less studied. Most of these studies has been performed in patients. And we have this from EFSA now recently that it's about 0.25 to 0.5 gram of EPA and DHA. Clearly, we have to, I think, remember, are we talking about healthy people or are we talking about patients? That I think we have to keep in mind. When it comes to inflammation and immune function, there's, of course, less evidence available, but we do see that there are, as mentioned before, that there are some claims that you have pain relief for rheumatoid arthritis and so on. You might even can reduce the amount of medication. So that's what we landed. When it comes to central nervous system and mental health function, we have much less data actually to play around with. But of course, early neurodevelopment is quite established. and the issue of for preterm infants and pregnant women. So this is not something new. We just go along with that the positive effects in various CNS disorders that actually we found from 0.5 to 2.8 grams. But again, as mentioned by Wallace, it's quite hard to identify which fatty acid, which product, what's the ratio between EPA and DHA. Is it EPA that's effective, or is it DHA, or both? So it's really hard to make any firm conclusions, but we notify that we have seen data that's quite positive. So when it comes to the positive health effects, general comment, we concluded that given a Western diet, the positive health effects were linked to EPA and DHA, but not alpha-linolenic acid. So, and this is a challenge, I think, when it comes to communication, because remember, alpha-linolenic is the essential fatty acid, but not so with EPA and DHA, per definition. So, but we have clearly found it was EPA and DHA that were effective. So, after some discussion, we had a meeting with the steering committee, and we all agreed that we come to this conclusion that the scientific steering committee recommends that considerations on adequate intakes of N-3 fatty acids should be specific on ALA, EPA, and DHA. Actually, what we are saying is that we should now recognize that these fatty acids are different. We have heard this earlier during the talks. Probably that's at least how we think, that we should define what are ALA doing, what's actually EPA doing, and what's DHA doing. I did not do this alone by far. There's been many members and external members also from the National Nutrition Council, Council of Nutrition. So this has been kind of linked and been gone through by several bodies in Norway. Now I have a bit time left, so just to put up some personal comments linked to data gaps in order to set an UL. I know that Wallace will also bring in some information here. But in general, there's a lack of trials in healthy people. And as mentioned also by Wallace, lack of trials assessing both the positive or including the adverse or the potential negative outcomes. So when we are trying to do this kind of evaluation, it's not a risk-benefit, but just an evaluation, we look for papers which have reported also on the negatives. And when we find that you have documented a positive effect, they also looked at potential negative outcomes, then that's a valid report that we can use. But in most cases, they don't even include any data on adverse effects. And remember, adverse effects could be just as simple as nausea, burping, and so on. If they just had included that, it would have benefited a lot. And then, what are the adverse effects? And how adverse are they really? Seem to actually now, what we've seen, linked to the fat intake, irrespective of the fatty acid composition of the oil. So, and there's also, I think, a quite important point here to make, that there's no causal link between the current risk factors and the disease. So we haven't really made this connection that this increase actually is a risk factor that we should, or for a certain disease. So this is also a gap that needs to be filled, I think. And then it's already been mentioned, and I think Michael put up this Crawford, the omega-6 versus the omega-3. And if we borrowed the data from Joseph Hibbeln, and he just, what I mean with this slide is that the background diet varies, of course, a lot. As we saw, the data on the outcomes varies a lot globally. And what Joe meant with this slide was simply to obtain an omega-3 index of about 12. You need actually, if you look at the Philippines, they have a quite low intake of the marine, EPA and DHA, but they don't have a high intake of omega-6, so they don't really need too much before to have a positive ratio or index. But in UK, they have a higher intake of omega-6, so they need a bit more of the omega-3 and EPA DHA. And of course, in US, where we have a really high intake of linoleic acid, you need quite a lot more of the omega-3. So I fully agree with Michael that probably the solution would be to, of course, decrease a lot the omega-6 intake. And then just a few personal comments. I think that we have to be really careful when we talk about this. Which population are we talking to, the healthy people or patients? We have to remember that EPA and DHA, including DPA, it's a limited resource. We have to probably focus much more on the individual fatty acids, what they are doing. And I put out no need to establish an EUL. Well, that's a quite strong statement. What I mean with this statement is that I would rather see that we really focus on what are these fatty acids doing at which concentration level, because I do not believe that we have to be up in the 5, 6, 7 grams or whatever. We have to find what dose are they effective within for healthy people and for sick people. And when you come to the patients, we have drug companies and they have to produce all the safety data. So for me, I think this is maybe not the way to push the industry and everybody to try to establish UL. I would rather encourage all of you guys, when you put together clinical trials, to make sure that the principal investigator does check for adverse effects and report on them. So we can clearly use those papers when we are doing future evaluations. Thank you very much.